Good morning and warm welcome to the fifth episode of the TaSHI webinar series. Today we are presenting you an exciting topic, task delegation from family physicians and psychiatrists to nurses, psychologists and nursing assistants in Lithuania. But before we start, I would like to share with you some technical details. The webinar will be recorded. We aim to share the recording on the TaSHI website in the coming days. And all participants are muted by default when joining the webinar. During the event, we encourage you to introduce yourself in the chat box. Please make sure you send your text to everyone. Later on, there will be a Q&A session in the webinar, and we ask you to write your questions in the chat box. Due to technical difficulties, the moderator of today's webinar will be Zoltán Cserháti, senior expert of the TaSHI project, and I wish you a very nice time with us. Zoltán, the floor is yours.
Thank you very much, Frusi. Welcome to everyone on this webinar of the TaSHI project, Empowering EU Health Policies on Task Shifting. And you will know that in this project we carried out pilots, and one of our most interesting pilots took place in Lithuania when not less than 5 different health professions were included. And I would like to give the floor to Diana Smaliukaite from the Ministry of Health in Lithuania to introduce the pilot, what happened in Lithuania in the mental health care.
Good morning, everyone. Thank you very much. And I will try to share my slides. So today I will present Lithuania case study pilot project on task shifting. So Lithuania faces uneven distribution of healthcare professionals, regional inequalities in access to healthcare services. And in some professions, for some professions, we have long waiting times. So task shifting is crucial in our country. So that's why we are joining this project and trying to test and to look how task shifting could help us to manage all these problems. And according to that, we implemented this pilot project. And the aim of this pilot project, the goal of it is to strengthen the quality of healthcare services, which are provided by family medicine doctors, psychiatrists through task shifting to other healthcare specialists. And you can see in this slide the objectives of the pilot project. So we identify the tasks that could be delegated to other primary healthcare specialists, also to identify the most effective ways of delegating tasks, to identify the competencies which should be additionally provided to nurses and nursing assistants, and to provide the recommendations for improvements to institutions which are implementing the policy. And when we determine the goal, objectives, and what changes we seek, we decided to involve 2 largest primary healthcare providers, so Centro Poliklinika and Kauno Miesto Poliklinika, and healthcare professionals working in these selected institutions have the most intense schedule in Lithuania. And because these two institutions cover patients for the 2 biggest cities in Lithuania, so they have around 200,000 inhabitants in the database. And you can see in this map, these 2 cities are Vilnius and Kaunas. What steps did we take to test task shifting in Lithuania? So first of all, we chose stakeholders, as I mentioned previously, and we reviewed existing legislations. Also, we selected the research type of the analysis. And the next step was we arranged focus group discussions. Also, we did We did an online survey and we identified tasks that could be transferred from family medicine doctors, psychiatrists to nurses. And later I will present the two last steps, which are implementation of the pilot project and legislation improvements. Focus groups were implemented in 2 different rounds of discussions, which took place last year. 18 healthcare professionals were involved, including general practitioners, psychiatrists, general practice nurses, and general practice nurses also who is working with psychiatrists. And during the focus discussions, we identified activities potentially to be shifted from doctors to nurses. So, for example, prescribing healthcare supplies, medical equipment for home care, patient consultation, management of healthcare prevention programs, writing referrals for tests or scans, referring to specialists, and etc. Also, we identified barriers for task shifting, so lack of competencies, patients' expectations, which is really, really high. Also, lack of training and other barriers which participants faced in their daily work. Also, we identified what measures to be taken. So development of nursing education programs is very, very important. Also, legislative changes is needed, and we need to create training programs. And the second part of the analysis is survey. The questionnaire of the survey aimed to explore knowledge, perception, attitudes of general practice nurses and psychiatrists, mental health nurses toward task shifting, experiences and practices in primary care. And 83 nurses participated in an online questionnaire from 2 mentioned institutions. The survey was conducted from 38 questions and divided into 4 parts. So personal data and general knowledge about task shifting, also task shifting in depth, also measures to be taken for task shifting and impact of task shifting. And you can see more questions what we asked in the survey. So if we talk about results, so results identified that activities to be shifted are prescription of care supplies and medical equipment, consultations, management of preventive programs, referrals for tests or scans, and barriers for task shifting are legal constraints, lack of competencies, patient expectations and attitudes, lack of training. And measures to be taken, legislative changes, education and training programs, as was mentioned a little bit before. And 44 nurses answered that they did perform tasks belonging to the scope of practice of GPs. And 35 nurses answered that they performed tasks belonging to the GPs several times per shift, and 11 answered that they performed tasks belonging to the GPs during each patient visit. 56 nurses answered that they could perform certain tasks, functions assigned to GPs and psychiatrists, and 32 nurses answered that task shifting could be useful in their professional practice. And what's next? So focus groups and the survey helped identify tasks which could be shifted from GPs to nurses, from psychiatrists to also their nurses. And the next step is to try to test them through nurses' professional practice during the pilot project, and to see what kind of maybe barriers they face and challenges they face. So the next step is the pilot project in the 2 institutions. Yes, and so for this presentation would be it. Thank you.
Thank you very much, Diana. If you have questions, then there will be a Q&A session after the presentations. But you can also write your questions now in the chat. So if any question occurs, that please don't hesitate to put it. And then you could see in this presentation that what a thorough preparation was required before starting the test shifting activities itself. Now we will turn into the implementation phase, and in the first presentation, Diana Smaliuk-Kaitene will present the experiences in Lithuania enabling task shifting to increase the accessibility of primary care provision in Lithuania. And then the presentation will be followed by the participants' point of view. We have Loreta Marmiene with us, the Deputy Director for Quality Management from Kaunas City Polyclinic, one of the providers in the pilot. So the first presentation, Diana, the floor is back to you.
The second presentation will focus on the pilot project and the legislation part. So the pilot project was run in previously mentioned 2 institutions, the same which participated in the focus groups, discussions, and the survey. And at the first part of the presentation, I will talk about the implementation of the pilot project. And in the second part of the presentation, I will talk about legislative improvements. So why have we decided to enable task shifting in the first place? So as I mentioned previously, Lithuania faces uneven distribution and other related problems with healthcare services provision, and we are trying to figure out how to manage these problems. And the task shifting is one of the cases that we could use to just change the situation related with these kind of issues. So the pilot study was conducted in 2 general practitioners' offices in two institutions, and the project was carried out for 3 months. Also, nurses performed tasks under family medicine doctors' supervision. And activities were shifted, for example, patients' consultation, follow-up, prescribing healthcare supplies and medical equipment for home care, also management of healthcare prevention programs, cardiovascular care, hypertension care, health promotion, Alzheimer's and dementia care, Parkinson's disease care, wound care, pain management, and diabetic care management. So it's really a wide range functions and tasks were tested in the pilot project. And tasks were split into 3 groups. So the tasks that could be performed independently, the task that could be performed with supervision and training from physicians, and tasks that could not be performed due to lack of competencies. And nurses filled daily sheets to provide information on performed assigned tasks. Yes, so during the pilot project, participants approved these tasks, which should be shifted to nurses. So, as I mentioned, writing referrals, management of healthcare prevention programs, writing referrals, prescribing medications, prescription extension, if correction not needed, and patient consultation on test results, education and health promotion, patient consultation on healthy lifestyle, assessing memory disorders by taking psychiatric charts, tests, wound dressing replacement, wound care, assessment and management. Also stitches removal. And the participants of the pilot project recommended changing the law so that nurses could lawfully do all of the aforementioned tasks. Also, participants provided insights that the medical norm of nurses should be more specific regarding the competencies of nurses and their tasks. Also suggested that the registration directly to the nurses is needed, and institutions already do that, but it could be implemented on a larger scale. Also, nurses emphasized that patients may object to direct registration because they prefer to visit a doctor rather than a nurse. And correlation of workload and remuneration was mentioned as one of the possible success factors. Also provided insight into the possibility of implementing a project of a similar nature in smaller healthcare institutions, because smaller healthcare institutions could have a little bit different processes or maybe services and etc. And also participants identified barriers for task shifting from family medicine family physicians to nurses, such as regulatory, legal constraints, patients' expectations. For example, public opinion. Patients generally feel that nurses are not able to deal with simple conditions and prefer to consult with GP for more complex conditions. So it's very, very important to work with patients also. Lack of competencies, lack of training, and lack of funding for trainings. And participants identified tasks that could be delegated from nurses to nurses' assistants. So these tasks could be like management of healthcare prevention programs, invitation, registration, ordering structured tests, and etc. Also prescribing healthcare supplies, medical equipment for home care, for example, wheelchairs and others. Data collection, preparation and submission for social care services, determination of disability, compensation for electricity, help providing if the patient lives alone, insurance, and etc. And also management of various documentations, helping accompanying patients who register from smaller cities to institutions based in bigger cities for continuous healthcare services. Also measuring blood pressure, high weight, and etc. And service of drinking and smoking prevention. And the conclusions, so the successful pilot project has led to the ministry's plan to start improving the law and other legal acts. A few changes will go into force in 2024. And my colleague Artūras Šimkus today will present the vision and the changes we are planning to do. And additionally, the pilot project participants emphasized that the critical success factor for nurses and nursing assistants is training. And according to that, we are trying to find the right funding, and we will try to put everything in place and to try to figure out how to put a right process and to get the best results of these kind of activities. So thank you very much.
Thank you very much, Diana. So now we could see the results from the perspective of the ministry who coordinated this task shifting action. And now I will give the floor to Loretta. How did it look like from the field? Pilot through the participants' eyes.
Okay, thank you very much for your attention. And today I would like to present the experience of the Kaunas City Polyclinic in this project. And Kaunas City Polyclinic participated in piloting of an identified function in our institution. And before project, patients were registered only at family doctors. And they shared the office with a nurse, and the reception was a separate operational unit. And before this project, patient also comes to nurse, but at the same time, we have project and we were implementation the lean methodology. And in this period, we defined key competences of nurses for team collaboration. And at the same time was very good this practice from TaSHI project and helped us a lot. And when we started, that we made a nurse competences matrix. And after the nurse competences assessment, we did training to improve the competences of nurses. And after the training, the nurses started working with new competences. And the result of the changes that family physicians worked without work phones and paper cards, and now patients are registered for nurse, for prevention programs, and for vaccination, and for prescription of medical assistant measures. And during the project, the nurses performed the following functions. The most diabetes care and independent assessment and implementation of preventive programs, and also assignment of studies for diagnosis health disorders and evaluation the labor test results. And also was the best that during the project, nurses under the supervision of doctors performing the following functions. It was referral making, pain management, also hypertension care, and cardiovascular disease care. And our project was this change, that quality attention to the patient, also with the best that coordinated patient pathway, and also improve the patient health literacy, and also coordinate implementation of preventive services, also improved workload distribution, and higher competence of team members. And like every project, and this project also has had some challenges, that lack of qualified team members, and low funding for employee training, and negative patient attitude to family doctors, team members. And also it was a problem that complicated legal regulation of services, and low patient motivation to take care for her health. And that's all. It's the best choice in Kaunas for patient, employees, and the partners. Thank you very much for your attention.
Thank you very much, Loretta. It's good to hear that this is the best choice. And we could follow how the prevention activities got closer to the patients by the nurses. Thank you very much. And both of you mentioned the legislation. Legislation at the start around the situational analysis, and at the end of the process. And if I remember, when you shared the progress of the project, the legislation was always an issue. It looked like a bottleneck, and it was a key part of the process. So the next presentation will be about the legal challenges in the practical implementation of task shifting. And the presenter will be Arturas Simkus, who is an advisor for Nursing and Long-Term Care Department of Ministry of Health of the Republic of Lithuania. Arturas, the floor is yours.
Okay, thank you, Zoltan. Hello, everybody. I will share my screen, and you can see the presentation. So most of things was said by Diana and Loretta. I was going to present to you, but the main thing is that we have to kind of reform, and we want to change our family doctors team. At the moment, we have two types of that team, and in 2030, we try to have a team consist of family doctor, two nurses, one midwife, also team administrator, physiotherapist, social worker, case manager, and lifestyle medicine professional. And our goal is to share the competences between those professionals, because at the moment we have family doctor who is responsible for all those competences and all those duties, and there is kind of a burden of administrative border of on family doctor, and they do not have enough time for patient. Please, next slide. Yes, here we have the main tasks of family doctors team. That's including assessment of health risk factors, early disease diagnosis and prevention programs, monitoring of patients with chronic disease, also preparation for consultation with a GP. It would be great to have this kind of activity. Also nursing procedures, maternity care, and usually at this time it depends on doctor, and recently we have changed the law of nursing and midwifery practice. And please, next slide. Next one. Another one. Okay, and it was quite a long. It took a long time to have changes in nursing practice and midwifery practice, to expand the competences, because in our country some competences they have to have basis on law, and to change the law you have to have support of politics. And after the COVID period, when the nurses was allowed to prescribe medicines, to prolong the treatment which was prescribed by the doctor before, it was kind of like a experiment or something, and the results was very good. I would say 95% of prescriptions was paid by the state, and that shows that nurses are competent and they have competences in this field, and they are able to do these duties. So here in yellow arrows, you can see what competencies we expect in the near future from nurses and nurse assistants. So nurses they can take some competences from physician, and nurse assistants, they should bring some competences from nurses. In this scenario, we are looking forward to because we have shortage of nurses, and in this case, we'd like to bring competences from nurses to nurse assistants that they will help with a shortage of nurses. In this case, suppose we suppose this will work. Please, next slide. Yes, as I said, that some competences must have a legal basis determined by law. So we had to go through our parliament and to discuss with universities who are responsible for nursing studies, and recently the law was accepted by our president, and today we have 2 months to prepare some legal acts to bring these new competences into practice. So it depends on the Ministry of Health for legal acts, as you can see in the right side of the slide. Please, next. Here is in yellow fields, you can see those new competences which was applied by the law. They are very important and brand new for all nurses community and for all specialist community, because those functions up till now was only on doctor's responsibility. It's very important that nurses will issue referrals for other personal healthcare services. That's mean obstetricians, nurse diabetologists, also to continue to prolong the appointment of the treatment for chronic disease, and from the summer they can issue the please, next slide. Yes, they can issue the sick leave, which will be paid also by the state, and sick leaves to care the sick family members. All these changes, we think will reduce the administrative burden of a family doctor. Also, the family doctors, they can consult more patient, and it will be better services for patients to get the family doctor's consultation. And next slide, please. Thank you for. That's all was I was going to say, and thank you for attention. If you have any questions, please free to ask.
Thank you very much to that. Now we have a Q&A panel, and we also have a chat. So if you have questions, just please write it to the panel or to the chat. And there are two questions in the Q&A panel. And the first is on legislation. What the challenges were in legislation, and how easy are they to change, or does nursing have a scope of practice which is legal defined? I think there was an answer for the last part, that the competencies and the scope of practice is laid down in legislation. But the first part, what were the biggest challenges, and how easy or how difficult was it to overcome? This is also this remains a question for Arturas or Diana. I don't know who would like to answer this.
Supposedly the biggest challenges are in the future. We have to discuss with the people, and we need to improve that. It's okay when you're consulting with a nurse, not with a doctor. That's the main change in the people's in their minds, because they usually get the consultation of doctor, and that's normal. This some new things, and they have to accept these changes. I would say that's the most issue for us, most biggest issue for us. Maybe
Yeah.
Diana, you have some notes.
Diana, please.
Yes, thank you. So, yeah, I agree with Arturas. And also, you know, when we are sometimes probably nurses thinks that if we are giving a new task from GPs, so all right, is everything is okay, is nice that we are trusting and we are giving some doctors functions and tasks to nurses, but also we need to think about remuneration, salaries, and etc. So it's very big issue in our case, because we are trying to raise the salaries, but it's not probably raised as much as nurses would like to. So this is one of the biggest challenge, and also trainings. But right now I think that we have the funds for that. So maybe this challenge is a little bit like not so big as salary thing.
Thank you, so if as we could see in the last presentation, continuous chronic care, medicine prescription, referrals, pregnancy care. So these are not just small part of the set of competencies. So they can really change the role of the health professional in primary care. And yes, that's a cultural issue. How inhabitants can accept nurses in tasks which is linked to the doctors in mind. Thank you very much. And there is another question from Corina Hinlopen. Loretta mentioned the challenge relating to the lack of patients to take interest in their health. Can you elaborate how this relates to the success of task shifting pilot? Do you mean to say that patients' interest in their health is different when they are treated by a nurse than by their family doctor? So it's pretty much similar, like the other issue was raised. So how we can get people to take interest in their health?
Suppose maybe kind of a campaign of communication, and also the notes from ministry, and also those two institutions which participated in the project. I look into Loretta. Maybe she will say some positive opinion from patients' opinions, and some examples. Of course, we hope that people will accept those new services, but of course it will take some of the time for people to accept in their minds. Loretta, maybe you some words about this?
Yes. Our people want to come to doctor. It's the best choice, yes, but we understand that not all question it's need the doctor. For all question need the doctor, yes, and we try new models that you can come not to doctor, but you can come also to nurse. Nurse have a very big training, and when they started talk with nurse, then okay, the next time they want to come to nurse, because with nurse they can also talk about medication, about also blood pressure, about family, and that's etc. And sometimes doctors say that you have to that a very important correct medication use, and they not here, not here and that. But when they come to nurse, the nurse say that it's very, very important. If you use this medication correct, then you come better and better. That we try this, and I say that this little by little, and they want to come also not only to doctor but also to nurse.
Yes, thank you very much. Yeah, it takes time, and they have to try it, of course. So, are there any other questions? Just please send it to us in the Q&A panel or in the chat. While we are waiting for the questions, now we were talking about the perspective of nurses in the survey, in the pilot, from the perspective of patients. And what about the doctors? So how did they react to task shifting? What was your experience with the doctors, with GPs?
Loretta, maybe you have some insights?
Yes, this project is very important and very interesting for our doctors, because they have very high workload. Yes, and when we shift this task for nurse and for administrator, and then the workload is lower, and they are happy. Not all, but and how say, and Arturas and Diana, we take a time, I think, for all.
Yes, and some doctors thinks that when we will shift a lot of tasks to nurses, so they are expecting that the administration will reduce doctors' number in the institution, and they would be replaced by nurses in some, in some maybe numbers. So I do not mean that every doctor will be replaced, but the number would be a little bit, smaller than it is now. So some doctors think that, so this is a challenge, because then they do not want to train, they do not want to give the tasks, and etc. But there's, I think, the bigger amount of doctors is happy about task shifting, and there's a little amount of doctors which is probably afraid, I think.
Thank you. We have another question. Can you please tell more about how consultation happened between professionals and decision makers, stakeholder management, the management of policymakers? Were there any difficulties of interest? Thank you. I think it goes to the representatives of the ministry, Diana or Arturas.
Yes, it will be some administrative challenges also to change the habits of CEO of organizations, because they have very big impact into behavior of the workforce. Here is also very important is the information company. I mean, some explanation and so on. What we expect and what kind of help they can get from us with that new habits, formation of new habits and so on.
And I would like to add a little bit. So I think that in this scope, like in TaSHI project, maybe there was not a lot of interest or some issues between professionals and decision makers, like ministry colleagues and etc. Because we all want changes in the system, and we all want to empower nurses. Maybe in the, I don't know, in next year when the legislation will be discussed in broader groups, then maybe something or someone will arise and will arise some questions. So probably we will have that. But at this point, all of us wanted the changes. So we discussed and we tried to find the best solutions and the best ways. So at this point, it's a little bit, brighter.
Okay, so there is understanding. And there's another question. What do the panel members think about the risk that nurses, who I understand are short in supply, will get even more work because tasks are shifted from doctor to nurse? Or is the burden then shifted to the nurse assistants? Are nurse assistants sufficient in supply? So you mentioned the cascade in task shifting from doctors to nurses and nurse assistant. What do you think about this burden?
We have not so good practice today in institutions when the nurse assistants they are used not like healthcare professionals. Suppose we need to use more use of competences they have and ability to do some functions, and we have to widen a little bit the competences, because in some perspective they're just doing the job of dispatcher or dealer or courier. I don't know how it's to say, but it's not a healthcare professional. You mean the functions they should be more like healthcare service, not just in general.
Yes, and I think that one more thing that yes, the nurses feel that burden that they have more work, and yes, we through some events we heard that like we want to put more and more tasks on nurses, and where we can shift that other tasks, maybe they can share with someone. So yes, nurse assistance is one of the options. But as you mentioned and asked about supply, yes, we have a little number of nurse assistants, and right now we are trying to increase that number. And right now we are thinking and planning to accept about 700 nurses assistant to the studies every year. So we hope that the number will increase in the years But sometimes when you are increasing the number and trying to accept more students, not everyone comes to the practice and etc. So this is also a question for us, but we are trying to implement some other measures regarding to empowering attraction to some regions, to some institutions in need. So we're trying to do our best, but yes, we have some issues with nurses and nurses assistant numbers. But I think that also I think that it's very important to give nurses more like huger tasks or like more competencies related tasks, because we cannot try to just leave and do not shift anything from doctors, because nurses should have like tasks which requires more competencies, and I think the nurses also happy about that. But we need to do something with overloads and etc. So I think we need to shift our like vision to how to maybe do some more work in other fields, not just to stop the shifting from doctors to nurses, because I think this is a good thing.